The chairpersons for the following are Sudipto Ghosh, Dr. Laxman Khaeria, Dr. Dharmanjay Sharma, Dr. Sudipto Ghosh, Dr. Laxman Khaeria, Dr. Dharmanjay Sharma. And now we are handing over the session to our chairpersons.
Good afternoon. May I request the speakers to come? The first speaker is Dr. K Sethy. He will be delivering talk on the non-surgical intervention for chronic pancreatitis, defining the indication and failures. Dr. Sethy.
Good afternoon. I would like to thank the entire organizing committee and my friend Dr. Sanjay Mandal for giving this opportunity. I will be speaking on non-surgical interventions of chronic pancreatitis, defining indications and failures. Specifically, I will talk about endoscopic and EUS interventions. I will not speak about any pharmacological management like pancreatic endocotherapy, medical management, opioids, or gabapentin, or antioxidants. So coming to the indications and endotherapy in chronic pancreatitis, indications are mainly two, that is pain management and management of complications. And we have many modalities of endotherapy. In the pain, we have pancreatic strictures that can be managed endoscopically with single or multiple stents or metal stents. Similarly, pancreatic caliculi can be managed with ESWL or laser-guided lithotripsy. And in case of rescue therapy of pain, we can do celiac pressure block by US guided. Then complication can be managed pseudocyst mainly endoscopically, either endosono, biliary strictures with multiple plastic stents or metal stenting, and recently we are doing gastric varices, endoscope US guided glue injection and coil injection. So coming to pain in chronic pancreatitis, the prevalence is almost more than 90%. Etiology is multifactorial, starting from neural pain, raised intraductal pressure, parenchymal pressure, and some upregulated pain mediators. Also, complications like pseudocyst, strictures play a role. Coming to main pancreatic obstruction, out of all MPD obstruction, stricture is the most common, that is almost 50%, stones are 18%, combination of stone and stricture in 30%. And we find associated pseudocysts in almost 15-20%. And how to define dominant PD strictures? If there is upstream MPD dilatation, which is more than 6 millimeter, or prevention of contrast medium outflow alongside the 6-pence catheter, which is inserted upstream to the stricture, then we call it dominant MPD stricture. Endoscopically, up to 90%, 98% patients can be managed with a stent. But one should avoid doing only dilatation. One should abandon this procedure of dilatation only. Clinically, 60 to 90% patient can be managed, mainly the pain part, that is absence of pain at 1 year post stent removal. And regarding strictures of MPD, all cases we do pancreatic sphincterotomy, and in addition one should do biliary sphincterotomy whenever there is cholangitis, jaundice, or dilated CBD. In case of difficult access to MPD, one should start with biliary sphincterotomy. And patients, if you require dilatation, start with either can have bougie or balloon or Sohendra type of stent retriever. And all patients, one should put a stent, at least a target size is 10 French, or you can put multiple stents, and one should do multiple stent exchanges over the year. This is one of my case. You can see the sphincterotomy and pancreatic stent placement. This is a case of minor papilla sphincterotomy and stenting. And what is the criteria used to terminate the PD stent removal? That is, if there is adequate pancreaduodenal contrast removal during the ERCP, or you can pass easy passage of 6-pence stent, you can remove the stent. How to define the relapses after MPD removal? Almost 50% patients can come back after the stent removal with pain, and restent is indicated almost 30% patients, and surgery is required up to 30% patients. In case of pancreatic division anatomy, it's very difficult to manage. That patient require longer time of stenting and multiple settings of stenting. This is multiple studies. You can see that there is an improvement of sustained pain relief up to 90% recently. What is the complication of endotherapy? We need to change the stent frequently, depending on the demand, or every 3 to 4 months. Fortunately, pancreatitis as such, acute pancreatitis as such, very mild in case of chronic pancreatitis, unlike regular ERCPs, and you can have stent migration and bleeding from the site. In case of very difficult stricture like refractory stricture, we have something called fully covered ACMS, and that can be retrieved, so possible to treat for at least a year, and results are pretty good. If you see the result, last 3-4 studies, you can see up to 100% there is a stricture resolution. This is one of my patients who put a bumpy stent, and patient did very well. Coming to pancreatic stones, ERCP sphincterotomy stone extraction can be done in case of small stone. ESWL and ERCP required in case of large stone or strictures. That can be, the stone fragmentation can be achieved in 90% patients. Long-term pain relief can be found in up to 80% patients. Similarly, if you fail in ESWL, you can do intraductal lithotripsy. This is one of the patients, small stone removed during ERCP from the PD. And what are the predictors of good outcome in case of endotherapy? Depending on the location of stone, short duration of disease, low frequency of pain, and if you achieve complete clearance of the PD, then you can have a good prediction. This is study, multiple studies. The largest studies from AIG Hyderabad by Dr. Tandon and Dr. Nagy. 5,000 patients, they did ESWL, almost 80% did well over the time. Basically, they have relief of pain. So what is the contraindication of ESWL? Mainly coagulation disorders, pregnancy, and there is a bone or aneurysm in the path of ESWL. Complications are very uncommon. And if you compare between endoscopy and surgical management of CP, 3-4 randomized trial, last one is into 2020. If you see, early surgery is better than endoscopic management and a selected group of patients. Coming to celiac block, plexus block of pain, basically we inject bupivacaine and steroid, can give excellent pain relief only for transient period. This is rescue therapy. This is one of my patients. We are doing US guided CPN, and usually this type of patient, they come back after a couple of months for the pain management. Now coming to pancreatic fluid collection. The natural history is different in case of acute pancreatitis and chronic pancreatitis. In case of chronic pancreatitis, only 30% they have a resolution rate. Otherwise, in case of acute pancreatitis, 90% of fluid collection, they disappear. So what is the indication of therapy in case of chronic pancreatitis? Symptomatic collection, compression of major vessels, interstitial hemorrhage, pleural fistula, any ascites related to pancreatitis, pancreatic ascites, and some more indications for the fluid collection drainage. ESG recommends endoscopy therapy should be the first line of managing this type of pancreatic fluid collections. We do both transpapillary and transmural approach. If you compare between surgery and US guided, the morbidity and mortalities are comparable, but lower mortality in case of endoscopic therapy. This is one of my patients, transmural drainage of PFC. We are dilating the tract, putting multiple plastic stents. You can see plastic stents here. And this is one of my patients which we have done US guided pseudocyst drainage. So now most of the patients or WIN, we do US guided pseudocyst drainage, put a Nagy stent or lamps to drain the fluid, and sometimes go back, do an endoscopy through the tract and take the necrotic metal out. You can see the guider inside the cyst cavity. And this is very rewarding procedure, but takes time. You can see the stent in the stomach side. We put a stent across the plastic stent across this stent just to prevent migration. Now coming to biliary obstruction in chronic pancreatitis. It's very common. Almost 20% have biliary obstruction in chronic pancreatitis over the time because of fibrosis, group pancreatitis, or complications. What is the indication of therapy for the biliary obstruction? Mainly those are symptomatic. those who have developed biliary cirrhosis, bile duct stone, or progression of biliary stricture over the time, even asymptomatic elevation of ALP or bilirubin should be managed endoscopically with stent placement in the bile duct. At the outset, one must rule out malignancy, and endoscopic placement of biliary stents start with 1 or 2, subsequently increase the number of stents and do stent exchange every 3 to 4 months. One should keep the stent at least for a year or 2 so that you can get rid of this stricture. This is one of my patients who are putting 3 stents in the CVD. If you see the studies, over the time people are using multiple stents. Nobody is putting now one stent, and covered stent should be placed in case of refractory strictures, and we can see the resolution of stricture up to 80 to 90% patients. So metal stent treatment of biliary obstruction, we have limited data, high migration rate, high rate of stent dysfunction, cost is definitely high, stent is very costly, and treatment overall is cost is higher. If you see 3 studies of metal stent in the CP, results are almost good, up to 90% of the stricture resolution on the metal stent use. Now coming to pancreatoscopy assisted lithotripsy. This is an emerging technology for the pulverizing large intertidal stones. Recent review, the technical success is 90%, fragmentation is 86%, very low adverse events, and data is comparable to IASWL. The drawback is the expertise not there, cost is very high, and one need to have a dilator system to do the pancreatoscopy. This is one of the patients who are doing spyglass treatment of the pancreatic stone. You can see the last picture showing the fragments of the white stones. Now coming to finally the gastric varix, endoscopic glue versus US guided coil embolization. This video you can see, we are doing a coil embolization of the gastric varix, very safe, it's a day care procedure, you can see the varix, and a patient can go back home same day. If you see the second video, this is earlier video, we are doing glue injection endoscopically. You can see why the bleed from the varix, difficult to manage during endoscopy, but US guided you can manage most of these patients. Now to summarize my talk, we all know the dictum, one size doesn't fit all the patients. So we have to choose between endotherapy versus surgery. The dictum of endoscopy first for the strictures and the stone still holds true in spite of the recent RCT in favor of early surgery. Poor responders to endoscopy should be referred for early surgery, and those who have biliary strictures because of pancreatitis, one should use fully covered metal stents. And options for large PD stones include IASWL and pancreatoscopy assisted lithotripsy. And the role of lifestyle modification, smoking and alcohol cessation and pharmacological therapy should not be underemphasized in the management of these patients. Thank you. Warm greetings from my team from Medica Hospital, my consultants, sisters, and the registrars. Thank you.
Thank you, Sudipto, for the nice lecture. And I think the more and more this scope of endoscopy is coming in other indications rather than the pancreatic stricture and the pancreatic stone therapy, as because of what he has mentioned about the ESCAPE trial, which shows clearly the early surgery. But I think a lot depends on the local resources also.
Yes.
Yeah. And the other problem is, how often do you do this pancreatic pseudocyst drainage?
Right now we are doing quite frequently, even in case of acute collections also. And earlier, like we had a discussion, like in last talk, there is a migration of metal stent inside the cavity, and a patient had, but we have seen in initial days, quite a bit number of patients, they have migrated the stent. The stent is a very small stent. So, but they don't have any sepsis, no pen abdomen, and we forgot the stent, and this is there for even 2 decades now. So, we are doing very regularly, and this is a very common procedure now in our department, and quite safe.
So the stent is left in the stomach itself?
Yeah, no, the stent has
migrated?
Yeah, migrated inside the cyst cavity,
into the
patient-
cyst cavity
yeah,
and lying in the cyst cavity.
Lying there for a couple of decades. Now patient is doing fine. There is no fistula, no pancreatitis, no thing. But in that case, because if you see many series, the early series, the stents are migrated and because not causing a symptom. Only thing in the future can cause, it can erode to the vessels or any
the hemorrhage.
yeah, thing. Otherwise, they're quite safe.
Okay. Any question from the floor?
Yes.
Please, Ramdeep.
Thank you, Pradipta. Excellent presentation. And in the turf war, you're winning all the ducks.
Yes.
No ducks left for us. Just wondering if you have any experience with post-surgery, having had to go in and do any endoscopic procedures. Any experience with that?
Yeah, basically post-surgery not for the assess the necrostomy, but for the rest of the management. Post-surgery, yes, patients are coming back because surgery done quite a few years back, now coming back with pain, difficult to access because of the altered anatomy. But in that case, we mostly do either some celiac block or if you have some remaining duct, or you can do some head area, you can do something. Otherwise, most of them, they come back. Not that after surgery they are cured, but they come back after a couple of years. We have to deal with these patients with mainly with medical therapy, enzymes, all these things, and sometimes a celiac plus a block. Not because sometimes anatomy is so altered, we cannot enter, we can't do anything.
I think especially after phrase, if they have done the phrase and LPJ, then it will be very difficult for us to enter.
Yeah.
Sir, good afternoon, sir.
If there
Sanjay,
is
anything?
Yes, sir.
Sanjay?
Actually, when Sanjay remembers, we used to do in maybe 10 years back, 1 year, 2 year, we had to all pancreatic patient surgeries. So finally, ultimately, end up doing mainly endoscopy therapy, or sometimes minimal invasive from the tract, from the endoscopy, and they did well.
Sir, one query. Sir, one
Okay.
query. In inflammatory head mass, how is the medical management, and after what time you are going to refer to surgery department in case of the head mass inflammatory?
This is very common scenario, inflammatory head mass. But first of all, you have to prove this is inflammatory head mass. So sometimes we continue the medical management. At the same time, we try to rule out any malignancy, first of all. Mainly because nowadays this pancreatic biopsy from the mass is very easy because of US. And if you convince there is no malignancy, then we manage with couple of months with medical management. At the same time, take out, because smoking and alcohol are really dangerous. It means smoking also. If you stop smoking alcohol, most of them, they do well. Otherwise, if there is a complication means there is a obstruction or there is a outlet obstruction, then in that case, we send the patient for surgery.
I think your comparative, we have to clearly understand why the surgery is becoming more important. See, the pancreatic surgery, chronic pancreatitis were directed towards tail, whether surgery or endoscopy. So endoscopically, it's standing mainly in the tail area now, whether it is stricture or not. No. In the surgery has shifted more towards management towards the head. Okay, so when surgeons the fear of managing head has gone, it's more shifted from LPJ to phrase, more duodenum preserving resection. There the results of surgery has increased, and because of the head management, the preserved tail has started function. This is what is happening in all the recent trials. Yeah. That is the major change. But so we can't compare this part where we are managing the head now compared to historical LPJ versus a tail management structure. So these two arms are different. We need more data to compare a head management strategy which we are following in the last 3 to 5 years versus a tail management strategy. These are two different apples and oranges. That's why the randomized trial are showing benefit for surgery, and it will show benefit for surgery because of the shift in this particular management. Yeah.
Like Dr. Ghosh was telling, the ESCAPE trial, there are lots of issue with the ESCAPE trial. Mainly, they have not done ESWL, some of the endotherapy they have not done. And what I feel still as an endoscopist, I am happy to deal with the head area also. So, only if I fail, still the dictum, as I told you, the endoscopy first approach should be there because of the cost and the morbidity, mortality is better. Even the outcome is better. Still, we want to deal with the head area also. Only some patients, those are we deal, then not suitable, then can go for surgery. But there is always a debate between this endoscopy and surgery.